Welcome everyone to the September CCO metrics tag meeting. We're just going to take a few minutes to make sure we admit everybody who's joining, and we'll get started in just a minute or two. All right, looks like we've been able to admit most folks who are trying to join the meeting. There may be some others who join as we go along, but we have quite a full agenda today. So I think we'll go ahead and get started. Welcome everyone to the September CCO Metrics Technical Advisory Group, or TAG meeting. I'm Jen Davis from OHA, Office of Health Analytics. I use she, her, hers pronouns. With that, I think we can go to the next slide. Okay, so first we'll just go over our typical logistics and housekeeping reminders for everyone. If you have any logistical or technology questions, please use the chat function to message Ashley Watchley. If you have other questions or comments, please raise your hand. We'll call on you, and then feel free to unmute yourself, speak. If you're able to put yourself on camera, we would appreciate that as well. And then in terms of naming convention, if you could make sure that your name and your organization name are represented in the participant list, that will save us a lot of time and make things easier tracking who attends these meetings. Next slide, please. So as I mentioned, we have quite a busy agenda today, hopefully lots of good information for you all. We'll do our usual program updates first. That will include a bit of an extended update on health equity measure reporting. Then we'll move into two presentations related to the social emotional health measure. We'll get an update from OPIP, the measure steward, and then we'll also hear from the Transformation Center about the technical assistance plan for that measure. Then we'll do a break that will probably land about 2 o'clock to 2:10. And then the last 50 minutes or so of the meeting will be about the social determinants of health measure. Next slide, please. We'll just go right ahead and move into updates then. I will turn it over to Rachel Burden to give the Transformation Center TA update.
Thanks, Jen. Hi, everyone. Rachel Burden, she, her from the Transformation Center. And I have 3 updates to share with you all. The first 2 are related to technical assistance for 2 of the upstream metrics, the system level social emotional health metric. As you can see, there is new technical assistance coming. We have shared, and in this slide, you can see a link to more details, a flyer that outlines the technical assistance that is coming for the social emotional health metric. I will drop that link in the chat when I'm done giving this update. And then similarly for the social needs screening metric, we have already started that technical assistance series with one introductory, what we call Cafe Connect, and those will be ongoing over the next year. Similarly, I will drop the link that you see here on this slide into the chat with more details about that technical assistance series and how to register. And then just in the interest of time, I'm going to move to the next slide. And the third thing here just to share is that we are asking that related to the RealD and SOGI data that you all have just very recently received. There will be some technical assistance and a data analytic institute offered by our friends at the Division of Equity and Inclusion. And we're asking you to please complete a survey. And there is a link here in this slide, which I will also drop in the chat when I'm done giving the update, that we're, again, ask you to complete this survey by the 29th, which is tomorrow. And it will help us get ready for that support and technical assistance around the Data Institute. We are going to be able to invite and allow up to 5 folks from each CCO to participate in these data institutes, and it's really going to dig in and provide support on how you all can use that data and interpret it. So please complete that survey. And again, if you haven't, you'll get it in the chat here in just a minute. So I will pause. That was really quick with those 3 updates, but since we have a packed agenda, I want to allow time for everyone else. Happy to take any quick questions. Otherwise, I'll pass it back to Jen.
Thank you, Rachel. I'm not seeing any questions at the moment, so I think we can move to the next slide, and I will pass it to Sarah Kleinschmidt to talk about metrics and scoring committee updates related to 2024 benchmarks and improvement targets.
Thanks, Jen. Happy Friday Eve, everyone. I'm Sarah Kleinschmidt. I use she, her pronouns. I'm the lead metrics program manager. I work closely with the metrics and scoring committee. I will talk about what is on the slide, but first I'm going to give you a couple other metrics and scoring committee updates. The first is that at their last meeting, they voted in new chairs. Dr. Jorge Ramirez Garcia from the University of Oregon will be their new chair, and Dr. Manu Chowdhury of Capital Dental will be their vice chair. And Jorge and Manu's chair terms actually begin in October. We will also have 2 new members joining the committee in October. So Lourdes Reina, who is a Community Health Development Director and who coordinates EOCCO's Community Advisory Council, will join as a CCO representative. And Nadia Busecruz, who is an outreach caseworker with the Cascade Age Project, is going to be joining as a member at large. So both of those folks will join at the October meeting. And I know that this group is very interested in decisions about 2024 benchmarks and improvement targets. At its last meeting, the committee made decisions, final decisions for most of the measures for 2024. But I want to call attention to the 5 measures on this slide. They are taking additional time. They want to be really thoughtful and consider additional input, et cetera, before making final decisions on these measures at their next meeting, which is on October 20th. Again, they are very much welcome public comment. Let's see. The next 2 slides do show you the final benchmark decisions that they have made. I'm not going to go into detail on those in the interest of time today, but I want to note that they are in the meeting packet today. So please look over those. They are also on the committee's webpage. So with that, I'm going to pause. It looks like there are some questions in the chat.
We have a request to go back a slide, I believe, to the draft. Yeah, I think that's the one they would like.
Yeah, so these are, I'll just note, these are the measures for which they have not made final decisions about benchmarks or improvement targets. So you can see the 2 immunization measures, the 2 dental care measures, and then diabetes, HbA1c port control. So the slide shows the staff recommendation that they were considering, and then on the right-hand side, it shows the draft selection from the committee thus far. At the next meeting, they may vote those in, or they may choose to change those. And it's, I should note, so this is in the packet today. You're seeing it on the slide. These slides were also sent out to the TAG distribution list and are available on the TAG webpage. And these slides as well that have the benchmarks are on the Metrics and Scoring Committee webpage now.
I'll drop a link in the chat to our TAG webpage just to make sure everyone has that bookmarked and available in case you didn't receive the slides or didn't have a chance to review them before the meeting. Any quick questions for Sarah before we move on? Okay, thank you, Sarah. Okay, I think we can advance a couple slides then. Perfect. I will turn it over to Katie Howard to talk about measurement year 2023 EHR reporting guidance.
Thanks. Each year, OHA publishes the CCO incentive metrics requirements for reporting on EHR-based measures. This guidance includes the following metrics: diabetes port control, depression screening and follow-up, cigarette smoking prevalence, drug and alcohol screening or SBIRT, and we still are reporting controlling high blood pressure. It's no longer incentivized, but reporting is ongoing since it was incentivized. We will be publishing the year 11 measurement year 2023 final guidance this fall. And so we anticipate that that will come out shortly.
Thank you, Katie. I think we'll stick with you for the next update as well. If we can go one more slide to talk about health equity measure reporting updates.
So I'm Katie Howard, they. I project manage the health equity measure, meaningful language access. We wanted to make sure that CCOs know that for contract reporting, that occurs quarterly and is full population, that we will continue to use the template from September 2022. It is available on the HSD website, and we have provided a link on the slides. We have 2 quarterly submissions that will still use this this template. The upcoming submission for October 1st, that is 12 months of data from July 2022 through June 2023. Again, the data required to be submitted is all 12 months of data, and it is full population with the template linked above. And then we will have the same submission template being used for the January 2024 submission, and that submission is the 12 months of data from October 2022 through September 2023 for full population in all 12 months. And so we have had some CCOs submitting only new visits that haven't yet been submitted. And we just want to emphasize that it's full population and should include all visits from that time period, even if they have been submitted before. Next slide. We had a question outstanding about component 1 wait time questions for measurement year 2023. We will be using the final measurement year 2024 component 1 questions 15 through 18. They will be retroactively applied to measurement year 2023 attestation report. We received a lot of public comment about the wait time questions, and OHA felt that it would make the most sense to make them retroactive to measurement year 2023. So we will be releasing a revised measurement year 2023 survey for component 1, the self-attestation, in October. Next slide. Okay, and that's it.
Thank you, Katie. All right,
Yeah.
we'll move into our next topic then, about the system level social emotional health metric. I will turn it over to Colleen Ruland from the Oregon Pediatric Improvement Partnership. And Colleen, I'll let you share your screen here so you can go ahead and drive slides. Thank you.
All right, Lydia, does that look like the right slide? All right. Hi, I'm Colleen Ruland. I am the director of the Oregon Pediatric Improvement Partnership, and I have my colleague, Lydia Chang. Lydia, do you want to introduce yourself?
Sure. I'm Lydia Chang. I'm a medical director at OPIP and a general pediatrician for the last 22 years, and a pediatrician at OHSU.
And we co-developed the health aspects of kindergarten readiness system level metric with the Children's Institute and are now leading the measure stewardship for the measure. And for folks to remember, the measure was developed based on kind of learnings from quality improvement work and a significant amount of public comment. So what I'm going to be highlighting today is just like I think I see in the materials for the SDOH metric. We're looking ahead to 2024 and wanting to kind of highlight some clarifications that we are making in the metric based on feedback and input we heard from all of you. This is a novel, first ever in the country metric. And so we really appreciate everyone sharing learnings and sharing ways that it could be improved to meet the intent and goal of the metric. And so our purpose today is to give highlights of those clarifications for the 2024 metric, so not this year's metric, and to kind of outline how they align with the intent and outline how they align with feedback. So I always like to start with like the why. Why are we doing what we're doing? Because the clarifications that we're making are aligned with the why and aligned with the intent of the metric and feedback that we heard. Then I'm going to go through the specific parts. As you all know, the system level metric has 4 different components. And so I'll kind of walk through the places where we've made clarifications based on input. There's one component, component 4, that it was already in the specs in 2023, but I wanted to just highlight for you that in 2024, those specs had highlighted the need for an action plan that was focused on issue-focused interventions. And then at the end, hoping to hear about any opportunities where we could provide information or answer your questions. So let's get to the most important part about the metric, the why. So way back in 2021, when we proposed this metric for adoption, the big picture goal for the metric was to really drive the improvements that we know were needed and that parents and providers had told us were needed in terms of making sure that children birth to 5 had equitable access to CCO covered services that support their social and emotional health. And so knowing that that is a complex system and knowing that there is a lot of roles that the CCO plays, the purpose of the system level metric was really to support you for 3 years to address the complex system level factors that lead to gaps in CCO covered services. And really meant to address the gaps that we currently have in our incentive metric set or in the previous metric set that kind of led to the state of where we are right now. And so as you all know, in component 3, you're asked to take a population-based perspective because outside of healthcare, so if you think about the pie that's on the right, there are a lot of different community partners that play a role in addressing social emotional health. And we think those community partners were really able to give you great insight and input about where you as a CCO should focus for your action plan, meaning the red piece of the pie. And so, as we have always stated, the scope of the measure are CCO covered services, but part of the reason in component 3, you were asked to engage partners that are outside the CCO is some of them are providing social emotional health services and have clearly articulated over the last decade and a half about the need for enhanced CCO covered services, because should they do their job, sometimes they need to refer to healthcare. So to go back to the why, and as I mentioned, there were focus groups and interviews with families that really helped guide us to the why of the metric. We heard way back in the development of this metric, and have subsequently continued to hear that families are noting that if they have a need for services that are within the healthcare sector, there is a gap. And there's a gap in terms of overall services, gap in culturally and linguistically responsive services, that should they be lucky enough to be identified or get services, that then there's nothing for them to be referred to. That it's often really confusing in terms of what's covered or not covered. And that we all know that having a service, you need to address the social determinants of health that may make it not likely for families to be able to get to those services. We also did extensive listening sessions of community-based providers, including healthcare, and then those early learning providers that are outside CCO covered services, but really need CCO covered services to improve. And they too noted that we need to focus on kind of the complex factors that lead to why we have the system that we do, including stigma, including training up people about how they identify and connect children to services, including addressing the limited workforce, including education, and including the need to kind of think about where are car seats parked and opportunities to co-locate services in a better way. I'm sorry, I just realized. So this slide you all have seen when we had to narrow down to like, what is the role of the CCO? And then narrow down to what kinds of services address those pain points that we heard from families and from providers, and what are the services that we can actually measure. We narrowed down to EPSDT clinically aligned services. So the first part of that is screening. So social emotional screening is a EPSDT clinical recommendation. And then children that are identified either through screening, clinical gestalt, or other factors then benefit from assessments. And then those children who have issues that are identified then need services. And some of them may be brief in nature, so 3 to 6 sessions, and some of them may be more robust in nature and include kind of more robust evidence-based treatment services. And so again, kind of aligned with the pain point, aligned for the need for upstream metrics, and aligned with the need for transformation. We've been kind of noting all along, and part of the reason that the 2024 action period really requires something to be focused on this issue-focused therapy services, is those were the biggest pain points that parents and providers had noted, both within the healthcare sector and outside the healthcare sector. So as we've been noting since the beginning adoption of the measure, the glide path is really meant to help think about the system, but then in 2025, the child level metric will be focused on that pain point, which is those issue-focused therapy services, so that we don't have a system that isn't ready to handle children within healthcare in particular that have issues and need supports. So thinking broadly about the system level measure and the complex set of factors, that's why the current component 1 includes those kind of broad set of factors that play a role in terms of CCO covered clinically recommended services. So you have screening and assessments and or issue focused services, and the current component 1 kind of looks at children that have received any of those, again, from CCO contracted providers. And the way we look at that is through claims. Okay, so just as a refresher, these are the 4 components of the metric. And so the really important part as the refresher is, why are you doing what you're doing if we're kind of leading our way towards that child level metric? And so the reason we wanted you to examine the REACH metric data is to just understand, what are current children currently receiving from your CCO contracted providers? Do you need action? And you probably all saw when you looked at your data, yes, action is needed. And hopefully you looked at that for populations that may have inequitable outcomes. And the second part of that system level metric is really meant to say, okay, if we look at CCO covered services and we see that most children are not getting clinically recommended CCO covered services, is it because we don't have services? Is it because the services that exist don't see young children? so that you could think about, relative to component 3, how you could get input from your community about where you might start in terms of quality improvement. And so recognizing that this was a staggered glide path, recognizing burden on CCOs, in year 1, you all did asset mapping of those providers, your CCO contracted providers that specifically you contract with for specialty behavioral health. So recognizing back to the kind of the 4 parts of the role that CCO contracted providers play, they play a role in therapy services. And then the next year, you updated that specialty behavioral health update, the year you're in right now, 2023. And then you expanded it to integrated behavioral health, because integrated behavioral health may play a role in providing assessments and providing brief interventions for young children. And so that's why you're looking right now of those primary care practices that we contract that said they had integrated behavioral health, how many of them see young children? Is that an opportunity for training and action? And then in this 3rd year in 2020, in the next year, 2024, so not this year, but next year, you're meant to expand that. And you're meant to expand that for those providers that you may have identified in year 1 and year 2 that were invited and required in component 3, because they are people that are able to address that pain point of issue-focused services, but they were not originally in your CCO contracted provider network. And so that's the goal of year 3. And it really was intentionally meant to build off year 1 and year 2, where you were engaging those providers in that component 3 work. And you may have identified that as one of your priority areas for your action plan, which is component 4. So again, why did we ask you to engage people outside of healthcare about a healthcare metric in terms of the CCO covered services? And the reason we did that is, 1, we thought it may be valuable to make sure that the people who are serving children, home visiting, early Head Start, relief nurseries, are aware when they identify a child who has a need for CCO covered services, what services exist. So that's why sharing of the asset map that you developed in component 2 is a required component of component 3, because maybe that's part of the reason children aren't getting into those services, is people may not know that those services are there. The other is that as you're thinking about how to improve access to services, again, those non-CCO contracted providers could give you a lot of input and insight about where to prioritize, because we know there are a lot of early learning providers who are doing within the scope of their work, not within healthcare, social emotional supports. And so they could give you some guidance about where you might prioritize and where you might start overall, and then for populations with historical and inequitable outcomes. So again, that year 3 early learning providers were really meant to be engaged because they're outside healthcare, but they have a need for CCO covered services. So we are now in this middle part of the glide path. So we are in 2023 to 2024, but again, looking forward to the future in terms of in 2025, the child level metric, with again, an explicit focus that the child level metric will be focused on the biggest place where we need transformation and where families and providers have told us is the biggest gap, which is on issue focused interventions. So, as we shared, part of the reason that the issue focused intervention therapy services is an exciting place for your action plan opportunities is they may exist in a variety of settings. Issue focused interventions may exist in specialty behavioral health, where you started asset mapping in year 1. They may exist within integrated behavioral health, what you added in year 2, this year in 2023. And then you may have identified the opportunity to enhance your CCO contracted providers for people who do issue-focused interventions that hadn't been part of your network, which is who you would be adding to your asset map in 2024. Okay, I'm sensitive to time, so I'm going to keep moving. All right, so what I want to now update is the clarifications that we are proposing for the 2024 technical specifications based on the input and learnings that we heard from all of you in the first year, 2022, and in this year to date in 2023, knowing that we're only in September of 2023, so there's still 3 more months. All right, so the first thing I want to just kind of highlight is as I go through my slides, if you see a box that is in gray and then green font, That is telling you the clarification. So on the left, I'll tell you the part of the system level specifications. And on the right, we'll talk through the proposed clarifications or improvements based on the feedback heard. Okay. All right. So let's start first with component 1, which is looking at what proportion of children 1 to 5 have received CCO covered clinical recommended services that are specific to social emotional health. And so Lydia, do you want to talk through the 3 improvements that we're making to that component 1 metric? One thing we'll just note is OPIP hypothesizes that this will only capture potentially more codes. It'll depend on your systems, but we don't propose that any of these changes would actually make the reach rates lower. We're actually just trying to capture services that were intended to be captured by the metric. So Lydia, you want to go and I'll progress your slides for you?
Yeah, thank you, Colleen. So as Colleen mentioned, we're proposing some refinements to the reach data code set. And it's, obviously this is the focus of the measure in terms of being able to see what's happening in the systems. And I'm going to walk through a little bit of the nitty-gritty just to make sure that you all understand and then see if you have any questions. But there are 3 areas we've received feedback and input on that we want to present today. The first set of codes that we're proposing some edits to are related to foster care assessments. The second are related to adding some diagnosis codes for the lists that require diagnosis pairing to count for the reach metric. And the third is just to remove some old CPT codes that are no longer in use. And I'll go over each of these 3 areas in detail over the next few slides and then pause for questions at the end. And as Colleen mentioned, we believe that these edits to the reach metric code list should actually capture more of the services that are happening. And that's the feedback that we've been wanting to get from CCOs to make sure we're capturing everything that is being done. So first, there are just a few codes related to foster care assessments that we want to go over. OPIS had conversations and received input from some CCOs, including some on this call, about CPT codes that are used for the assessment of foster care children that are in alignment with the OHA's assessment for children in DHS custody incentive measure. These assessment codes that are included in the DHS foster care metric were part of the reach metric from the start, as this would fulfill the intent of the system level social emotional metric of providing social emotional services to children 1 to 5. Now, just as a reminder, the reach code lists include lists 1 and 2, which are codes related to assessment or screening, and then lists 3, 4, and 5, which are codes related to interventions or therapy services. A few of the foster care assessment codes were initially placed in the therapy service lists, so lists 3 through 5, as there was some thought that these assessments were, sort of services the system was providing for DHS children. But it's clear that these codes refer to just the assessments being done and not any therapy services being provided. And so we are proposing to move the first code that you see here, the H1011, which is family assessment by licensed behavior health professional for state-defined purposes, that code to list 1 to be consistent about assessments and then therapy services. And then the other foster care assessment code we received input about is code H2000 with the TG modifier that you'll see in the second bullet, which is commonly used for the initial assessment of foster care children and represents mental health assessments using CANS, so the Child and Adolescent Needs and Strengths tool, rather than including a very general code, so the H2000, which is not specific to social emotional services at all. We wanted to be sure we capture these foster care assessments without restricting it to needing a diagnosis or provider taxonomy pairing, which is a list it was initially in. So understanding now that the H2000 with the TG modifier code is used specifically for mental health assessments of children in DHS custody, we're proposing adding that code to list 1 and removing the more general code in list 5. So those are just the very basic things that we are proposing for the foster care assessment codes. And then you can go to the next slide, Colleen. So the second set of proposed code adjustments are related to the diagnosis codes that are listed in 2, 4, and 5 of the reach metric. And those are codes, the diagnosis codes that are required for pairing with the CPT codes. These, so for that list, these diagnosis codes were informed by the OHA diagnostic crosswalk for birth to 5, which is a list of mental health codes that could apply to young children, birth to 5, when seeing them for behavioral health supports. We took these diagnoses, so in the reach metric, the diagnoses were chosen in consultation with OHA's behavioral health team and health analytics team through a really detailed and kind of valuable collaborative process of determining what mental health diagnoses were appropriate and potentially applicable to young children birth to 5, and also above the line on the prioritized list. But in hearing from integrated behavioral health providers in primary care, we're aware of some services that they're providing and appropriately billing for when providing social emotional supports for young children, but that some of those diagnosis codes that would pair with those CPT codes were not initially included in the REACH metric. And that's just because that the specialty mental health lens that was used to create that diagnostic crosswalk for birth to 5. And this really impacts integrated behavioral health and young children in primary care with milder presentations. So you'll see on this list today, we're proposing including the additional diagnoses that are listed on this slide, which can be paired with some of the more common CPT codes used by behavioral health providers, both specialty and integrated in primary care, rather than limiting to the diagnostic crosswalk, which was created with the specialty mental health lens. So this should actually really help the diagnosis pairing for certain procedure codes, such as preventative medicine counseling, which is used in primary care to a pretty large extent. And then next slide. In case you haven't seen enough of codes today, this last slide should be very straightforward. We are proposing to remove old CPT codes that are no longer in use and have been retired or replaced. We actually received a lot of questions like, why are there so many codes that are old? And these were originally included in the code list because the REACH data was a look back, and we needed to make sure to capture any transitioning codes that may still have been in use. But we're now really, I think, able and safe to remove these codes that were retired since about 2020. So these are the codes and the lists that they're originally from, and we have asked to remove those for 2024 for the REACH metric. And so the next slide, but we're just going to pause now to just make sure in walking through those that there's no questions. Oh, Colleen, do you have anything to add?
I was just going to say, since we started a little late, I'm wondering if we go through all of them and ask questions. Is that okay, Jen? Just because I want to be thoughtful about our time.
Yes, that's totally fine. And if you want to take the extra 2 minutes at the end, I think that'll be okay.
Yeah, we want to hear any questions that come up. Okay, so then the things I'm going to highlight now relate to clarifications related to component 2, 3, and then 4. It's not any change. We're just highlighting that it in the specs year 4, the action plan for 2024 is was modified, like enhanced, and so we just wanted to highlight that it's not a change, just a reminder. So for asset mapping. So again, if you see something on a gray box, that means it is a clarification or to the component of the specs. So within component 2 in 2024, next year, there are 3 asset maps or three sectors that you asset map: specialty behavioral health, integrated behavioral health, and then community-based social emotional services that you're exploring to be part of your CCO contracted provider network. So if you want a quick high-level summary of like what the clarifications are that we added, slide 22 is your friend. They were sent out beforehand. They're posted on the website. The first update I want to share is in the specifications, we have a visual that shows you evidence-based methodologies or services that had an evidence rating of 1 to 3. And so every year, OPIP looks to see if there are any additional evidence-based methodologies that serve birth to 5 that have a 1 to 3 evidence rating. And so this year there's one modality that has received an evidence rating of a 3, and it's promoting first relationships. So in this visual, you will see that we added promoting first relationships. You see it's in the orange because that now has an evidence rating of a 3. And then in terms of the asset mapping, that would just mean that that's added as an option of a modality some may provide in terms of your community. The second is that we heard a lot of feedback around the integrated behavioral health asset mapping, and in particular, the section that was around capacity. So again, let's go to the why. Why are you looking at like, does integrated behavioral health see young children and how many could they see? It's because you were trying to understand if that's an asset in your community for your action plan. And so we heard you all that in trying to look forward, that was really difficult because for integrated behavioral health, they don't necessarily just hold spots for birth to 5. And so based on your feedback, And based on alignment with the intent of the goal of you're just trying to understand, do they see young children? And they may not bill if they see young children in an integrated behavioral health setting. We're just proposing that row switch based on your feedback to be looking back rather than looking forward. And so providers can look back the last 2 months and note how many patients they saw that were birth to 5 that they provided issue-focused interventions. And then that way, that addresses some of the feedback we all heard from you about the difficulty of looking forward, but it still gives you the information that is intended in the asset map of, is this an asset in terms of your provider contracted network? And are they seeing young children, but you may not be able to be capturing it in terms of the claims data. Then, as you know, in the integrated behavioral health asset mapping, we also list out the evidence-based services. So one of the really important places of feedback that we heard from you was that often integrated behavioral health is not implementing a evidence-based methodology in its pure form, parental child interaction therapy, CPP. But instead, the appropriate things that integrated behavioral health do are parent management and generalized evidence-informed therapies. They're not sticking to one modality. And so we really appreciated hearing that and appreciate that that's largely the largest modality that integrated behavioral health provides. And so we are adding to the asset map that option that you all had put in terms of the other, and to be able to give you the option for integrated behavioral health to tell you they're doing generalized parent management strategies. And then again, the applicable codes that integrated behavioral health may bill related to those general parent management strategies. Again, because the asset maps, both for specialty behavioral health and integrated behavioral health, list evidence-based modalities that have a scientific rating of 1 to 3. In the integrated behavioral health, we would also add the promoting first relationships. Again, I don't think this is going to impact the integrated behavioral health asset mapping, because I don't know that we've ever met an integrated behavioral health provider that provides promoting first relationships, but we need to make sure that we're aligning with some of those evidence-based methodologies and ratings. For 2.3, we are adding clarification language to just make sure we're being super clear with the intent and goal of this metric, which is to improve CCO covered services. And so this gray language that I have on the right is language that we are adding to the specs to just clarify the goal, intent, and purpose of the additional asset mapping in year 3. So again, in years 1 through 2, last year and this year, you convened, they were required, early learning, family support services, and other community-based services. It was important because they provide social emotional services in non-healthcare settings, not the scope of this metric, but could provide you with input on priority needs for young children. Through these discussions, though, you may have identified opportunities to expand and include them in your CCO contracted network, and that may be part of your action plan. So the purpose of this this additional asset map is to be able to capture those people, because they don't live within specialty behavioral health and they don't live within integrated behavioral health. And so what you are asset mapping is any of those additional community-based providers that you are exploring becoming part of your CCO contracted network, which is the scope of this metric. If you are not exploring any of these additional agencies to be a CCO contracted provider, then you don't need to do this asset mapping, because the whole point of the asset mapping is asset mapping providers that are within your CCO contracted network. So what we wanted to do is just add a row for you. I know some people had said, like, if I'm not exploring that, do I just leave it blank? And so great feedback. Thank you. We appreciate it. And so we added a row that says not applicable to the year 3 asset map for these early learning providers. And then we just added a clarification to the column label to make sure that it's aligned with the intent. So if some of you have started looking at this table in the specs, you'll see that that first row, not applicable, is a new row. And then you'll see that language in the upper left is the same language that we're also adding in terms of bullets, in terms of the specifications. Okay, the last thing is under the community engage, or not the last thing, 2 more things, sorry. As you know, in 2023, so this year, there was language added around component 3 in the specifications. We've continued to hear from community-based providers that CCOs aren't necessarily providing the data, 1.1, providing the data by populations with historical and equitable outcomes, 1.2, or providing the asset map, component 2. And so even though we added those specifications, we're still hearing from partners that that's not happening. And we need to make sure that this is a reliable and valid metric. And so in terms of aligning with that language that's already in the specifications, we're just adding a simple guide for you, and then that'll be able to help OHA if a partner says they didn't do that, to say, well, the CCO did attest to this. So basically, if you see those green rows, they just align with the language that was already in the specs that you shared 1.1, the data, you shared 1.2, the data for historical populations with historical and equitable outcomes, and that you shared the applicable asset maps. And again, because these are the specs for 2024, it would include those 3 different provider types of contracted, CCO contracted providers that you would be doing asset mapping for. Okay, and then the last thing is not a clarification. It is not a change. It's always been in the spec, but we're just highlighting it for you in terms of in 2024. So remember, in 2024, we noted that it'll be required, or sorry, in 2023, we noted that it'll be required in 2024 to do an action that focuses on issue-focused therapy services, because again, that's the largest pain point. And again, this work is meant to be a glide path to the child level measure. And again, the child level measure will be focused on those therapy services. So the thing we just wanted to highlight, it was already in the specs, is that in measurement year 3, which will be next year, 2024, you will need to kind of note that you have a target area that's focused on issue-focused services. Okay, so if there's any concerns or questions about these updates, love to hear them. You could put them in the chat. Lydia and I could stay on for a while to look and see. If you have questions or concerns, love to hear what your solutions are. Our door is open. Super interested to hear any feedback. So I provided my email. We need to provide the 2024 specifications to OHA by the end of the month. So if you could get us feedback by 10/12/23, Lydia and I will do our best to respond or incorporate any feedback, but I would love to hear any questions or clarifications that we could provide today. And again, we gave our sites to Jen on Monday, and so I see them posted on the TAG website. So all of the stuff I just covered is also on the website.
Thank you, Colleen. If you would like to take another 3 or 4 minutes and verbally answer any questions, we can allot that time.
Awesome.
Otherwise,
Thank
yeah, if
you
you want to answer in the chat or via email later, that's fine too.
Yeah, I'd love to. Is the intention to include screening and assessments rendered by primary care providers or pediatricians in the specs? So Courtney, in terms of EPSED clinical recommendations, the intention is to capture screening, social emotional screenings that are recommended. So 96217 is the EPSED Bright Futures Aligned code that is recommended by the AAP to capture screening. And so that's why it's included in list 1. List 1 doesn't require a provider type. So anybody that bills that would capture that screening. And for the most part, the most people that use 96127 are primary care providers. One thing I will just note, because I think some people have said this, is some folks have asked, like, well, why aren't you including developmental screening? Developmental screening is a separate clinical recommendation that we had an incentive metric for 2013 to 2019. And that claim is 96110. So that is not included in this because we are aligning with Bright Futures recommendations around social emotional screening and the services. So in terms of that first bucket, the screening and assessment, it is meant to capture screenings and assessments that would happen by the range of providers that are in the system. And then Lance, why have the Z codes relative to screening been excluded other than a handful? Again, for the screening codes, we don't actually require any diagnostic pairing, Lance. The screening codes they stand as full. So there's not like an additional bar that is needed around the screening codes. They're in list 1. So list 1 doesn't require a provider type. It doesn't require a diagnosis type. Hope that helps. I think another question you all maybe have asked, and I'd be happy to answer, is autism screening, for example. And autism screening is a separate EPSDD Bright Futures clinical recommendation. And for autism screening, the AAP recommendation, for example, would be like a 96110, I think, with a Z code. But this metric is aligned with the social emotional EPSDD Bright Futures recommendation. So that's why, again, it's not included in that way, because we're aligning with that row in terms of the Bright Futures recommendations, which I'd be happy to send to you all. Taylor, I'm seeing your question about licensed clinics are the only master level of behavioral health with taxonomies included in their reach. I really want to nip this kind of taxonomy requirement. List 3 requires no provider taxonomy, and that's 90%. Well, list 3 and list 4 require no provider taxonomy. And that is the lion's share of codes that behavioral health clinicians would use. Like the codes that are in list 5, which require provider taxonomy, and likely we'll hear feedback that maybe those aren't good ones to include in the future, are trying to capture kind of all the other potential random stuff that could occur. And so again, list 5 was meant to be like a catch-all for anything we wouldn't have captured in list 3 and list 4. I will say in working over the last decade with behavioral health providers and integrated behavioral health, I know very few of them that are using list 5. That's actually not the standard of care that they should be using in terms of claims. So for the most part, things that licensed clinic social workers would be doing would be captured in list 3 and list 4. So by excluding the other Z codes, you are limiting this only to be validated by CPT in a PCP setting, correct? Lydia, do you want to, I feel like I'm answering this, but, and UHA, I'd be happy to have a call with you to help, because I think all 3 of you are from the same CCO, so I'd be happy to talk through this if helpful. But Lydia, do you want to help talk through that a little bit?
Yeah, I'm actually not totally clear what the question is, only because the screening assessments that we're talking about do not need a diagnosis pairing, as long as it's a clear social emotional assessment, like the health behavior assessments, the social emotional screenings, those are all going to count without any pairing. The Z codes that you're seeing on the diagnosis list are ones that were chosen because they are specific to birth to 5 and specific to sort of social emotional sort of diagnoses that could be at risk for social emotional issues. And so I think if you have specific ones, Lance, I'm happy to sort of look at those and just make sure, because we do want to hear feedback and make sure we're not missing anything, but I'm not quite understanding the other Z codes that you're worried about. So I just want to be sure that we answer that at a different time, I think.
And Lydia and Colleen, thank you. I'm sorry to have to cut off the questions verbally. We've just got a lot of presentations to get through today. So feel free to, if you're available, stay in the chat. Otherwise, thank you for this presentation and all of the answers. And I know that you left your contact information, and folks are probably already aware of that if they need to get in contact with you for more questions. Thank you so much. Ashley, I think we can bring back up the main set of slides, and we'll stay on the social emotional health topic, but shift a bit to talk a little more in depth about the technical assistance plan. So I will turn it over to Rachel Burden at this point. Thanks.
Thanks, Jen, and thanks, Colleen and Lydia. Really great to hear the updates coming. So more on this metric, the system level social emotional health metric, and what some of the support for implementation and TA will look like in this coming year. We can skip ahead, Ashley, to the next kind of 2 slides, actually. Keep going. There we go. So actually back up one. Thank you. So we are partnering, as some of you already know, with ORPRA, Oregon Rural Practice-Based Research Network, to plot out and offer implementation support and TA for this metric. As many of you know, we partner with ORPRN to implement another of the quality incentive metrics, the social needs screening metric, as well as a few of the payment programs. And you can see here ORPRN's mission, and we are working with them over the next 2 years, but what I'm going to focus on today is just over this next year, short of a year, what the TA plan will look like. So let's go to the next slide, Ashley. So 3 kind of big buckets of support over the next year we have developed, and the way that we have come to the TA plan is really threefold. We've talked with many of you earlier in the spring. I met with 11 CCOs to hear about challenges, successes, and needs for support in this systems change metric. We distributed a survey with those same questions that we talked about verbally to hear back from CCOs. And then we also, of course, ORPRN and OHA have reviewed the deliverables, specifically the asset maps and action plans to really help inform the TA. Let's go to the next slide, Ashley, thank you. And so these 3 kind of buckets of support for implementing this metric are: 1, communications about social emotional health; 2, understanding social emotional health system and making improvements to the system broadly; and then 3, engaging new social emotional partners with the health system and the health sector. And I'm going to just dig in briefly to those 3 and say a little bit more about what the support is going to look like. So let's go to the next slide. So for communications, we have heard from many of you that just some actually basic communications about what is social emotional health, why is it important, and for families and or for providers and different types of providers, what is needed, what are the action steps. So we'll be developing communications documents, 1 or 2 page flyers. Will support kind of understanding and use of those through a webinar and through learning collaborative. So 2 kind of touch points around communications and use of those communications documents. So let's go to the next slide. The second kind of area of TA and implementation support, again, is around understanding the system and making improvements in the system. And so we are starting to work on what we're calling a system map to really understand the health systems and health sectors, kind of levers and areas within the health system, as well as other parts of the system that touch kids 0 to 5 and their social emotional health, and how that all of those pieces of the system work together. Again, we will be sharing the system map via webinars and learning collaboratives. Those are the 2 touch points that we have with you all CCOs and your invited partners. And then the third, if we can go to the next slide, the third, again, area of implementation support is around engaging new social emotional partners, as Colleen kind of alluded to, as you are asset mapping and then planning some action steps to broaden that network, that provider network. If you're adding new partners, let's dig into who those partners are, what they need in order to participate in the network and provide some of those brief intervention or more substantial intervention services. So this area of support will be later next spring, so after the new year, and it's a little bit less formed, and we're going to be actually asking you for a little more input towards what is going to be the most helpful at that point to share with you. But things that it might include are around billing and coding guidance for multiple types of providers and partners. And again, we will be developing some documentation around that, likely with our measure stewards, other experts and subject matter experts in the field, and have touch points with you all via webinar and learning collaborative. So just a glimpse into those 3 areas. Let's go to the next slide. I think I have 1 or 2 more. Oh, right. So I shared this earlier in the chat. This is just the actual flyer with the link where you can register for any of these TA and implementation support opportunities. So please just note that. It's in the chat. It's here. It'll be in the slide deck that that is sent out. And then if we go to the next slide, not sure how much time we have, but we were going to just have any time for question, discussion, but want to do a time check with Jen.
Yeah, I think we can go to 2:05, so we have 5 more minutes if
Okay.
we'd like to do this.
I think what I'd like to do is actually, if we can just jump to the next slide and then we'll go back to this one. As I mentioned in that kind of area of the last bucket of TA that we're going to be offering, we actually would like to get some of your feedback now for that session later in the spring. And there is a survey link. And again, I'm going to drop this in the chat for all of you. But just wanted to call out that in addition to talking now for just a few minutes, answering questions, hearing any initial reaction that you have to this, we will ask for your input via a survey as well. So this isn't the only opportunity. And then the other piece I want to call out here is as we are developing communications documents to talk about social emotional health, I know that at least a couple of CCOs really called this out as a big need and wanted to participate in development of those documents. So if you are interested in contributing to the content of those documents, you can see here, please contact Sarah Wild, who is part of the Orphan team that we're working closely with. And we are happy to work with you to do that. So again, if you want to pop back, Ashley, just to the previous slide, and if anybody wants to chime in via the chat or come off mute and ask questions or just give some initial reaction, I'm all ears.
Thanks, Rachel. We'll just pause a minute to let folks type in the chat if they're doing so. And as Rachel mentioned, if you'd like to speak, just raise your hand and you can come off mute. I see a question from Katie Unger. Is the crosswalk of the asset maps and action plans that were printed shareable?
Yeah, sorry, you caught me in the middle of putting something in the chat. Is it shareable? You know, that's a good question. I have kept it kind of confidential because when I talked with the 11 CCOs, I didn't ask if I could share that information. So I think that's something that I would want to check back with each of the CCOs that I talked to see if that information that was shared is something that's okay. So that would take a little time for me to hear back from everybody.
That sounds good. I know that they're all publicly posted on the website anyhow. And so I was just curious because as I was working with our medical director, she was curious to see other CCOs, how they approached it. So I would love to understand if that crosswalk is available. Thanks in advance.
And I do see a comment also from Jeff Goldseth saying the collabs were good for touching base across CCOs, also share obstacles and issues and successes. Some CCOs also shared their data, which is valuable to continue doing.
Great, thanks so much, Jeff.
Well, thank you, Rachel. I'm not seeing any other comments in the chat at this time, but I know you provided contact information for folks as well as links to the flyer and whatnot. So hopefully if there is more feedback, you'll get that either in the survey or or via email. So thank you for taking the time to go over these things with us today.
Sure thing, Jen.
Okay, I think we can move to the next slide, which should be our, yeah, there's the contact info, one more, thank you. The break time. So we're gonna move that 5 minutes as well. So it's 2:05 right now. We will resume at 2:15. So I'm going to go on mute, stop video, but I will see you all in about 10 minutes or so. All right, everyone, just a warning or alert to start coming back. We will resume in about 1 minute. Okay, we are at 2:15, so hopefully everybody had a chance to get up and stretch a little bit. At this time, I will turn it over to Katie Howard, who will lead us through the rest of the meeting with a presentation about the social determinants of health measure. So Katie, take it away.
Thanks, Jen. My pronouns are she, they. I am the OHA technical lead for the social determinants of health, social needs screening and referral metric. Next slide. I did put in the chat a quick cheat sheet for the SDOH measure. I'm going to be talking about component 1 and 2 and also rates 1, 2, and 3. So I hope that guide is helpful. Today I'm going to cover some updates first about the SDOH measure, then I'll discuss the draft measurement year 2024 recommendations. Each of the sections I will be talking about come into effect at different times. Component 1 started in measurement year 2023. The draft measurement year 2024 specifications will impact the measurement year 2024 CCO self-assessment in component 1. Component 2, the quantitative component of the measure, is projected to start in measurement year 2025. It is included in the draft specifications to support future planning. The data collection template in Appendix 1 and the screening tool approval process in Appendix 2 are new. These appendices support Component 2. I will take questions at the end of each section on the agenda. Next slide. A reminder that feedback is due tomorrow on the measurement year 2023 draft self-attestation survey, and there's a link provided there for the survey. Next slide. OHA continues to offer TA for measurement year 2024. Rachel covered this a little bit at the beginning of the meeting, but I'm going to go through it in a little bit more detail. Again, ORPRN is our TA contractor. They are the Oregon Rural Practice-Based Research Network at OHSU. The CAFE Connect event series will feature experts in the field and case studies throughout Oregon and around the country. It centers opportunities for CCOs, community-based organizations, and providers to engage in dialogue. The Learning Collaborative will focus on measure requirements and high priority needs of CCOs. We hope 1 to 3 representatives from each CCO who are most directly involved in metric implementation will join to share their strategies and processes around metric implementation. Directly after this meeting is the first Learning Collaborative meeting for the new TA period, and Rachel and I will be at that meeting as well. ORPRN will also host bi-monthly office hours for CCO technical leads, which will serve as informal drop-in sessions for additional question and answer. We also have one-on-one technical assistance for CCOs. You can reach out to Claire Londigan, whose email is on the slide, for one-on-one technical assistance inquiries. Any questions about that? Okay, next slide. I'll now go over the draft specifications and I'll start with the timeline. Next slide. Thanks. This year, OHA is providing 2 opportunities for public comment on the measurement year 2024 draft specifications. The first public comment period will end on October 27th. OHA will then make adjustments to the specifications based on the feedback from the first round. I'll present again at the November CCO tag meeting detailing the feedback and OHA's responses. For the modified measurement year 2024 draft specifications, a second round of public comment will begin on November 21st and end on December 12th. The second round of public comment will occur when all draft incentive measure specifications are released for feedback. The final technical specifications are published on December 29th for all incentive measures. Any questions about the timeline? Okay, next slide. Now I'll go through component one. The next two slides show the must-pass elements for CCOs for component one. This component is structural and self-attestation. It has 3 domains: screening practices, referral practices and resources, and data collection and sharing. CCOs lead and are accountable for doing these activities. Each of the domain has a list of must-pass elements for the measurement year. Measurement year 2023 self-assessment will be based on the CCO fulfilling each element by December 31st, 2023. The self-assessment for measurement year 2023 is based on the measurement year 2023 technical specifications. The measurement year 2024 column will be based on the measurement year 2024 specifications. Each CCO must pass the element as of December 31st, 2024 to obtain credit for the measure. Next slide. Here are the 2 remaining domains: referral practices and data collection and sharing. You can see that a higher proportion of these elements begin in measurement year 2024 than for the screening domain. Next slide. The proposed component one clarifications and deletions are meant to provide greater clarity on what is needed when attesting to have met each element. The majority of these clarifications came up during the last technical assistance period for the SDOH metric. We really appreciate the thoughtfulness of the questions from CCOs, community partners, and providers. Throughout component one, the blue text signifies where words were added. We did not track deletions except for element 13 where there were only deletions. Element 2 is about written policies on training for screenings. The changes clarify that CCOs are required to share the training policy with partners, but are not required to provide training to partner only CCO staff. Element 6 identifies screening tools or screening questions in use, including available language. We clarified that CCO should track the languages made available for each screening tool, and the element does not require CCOs to track what was actually used by participants. While CCOs can still track what languages are used, it is not a requirement for element 6. Next slide. Element 7 assesses whether OHA approved screening tools are being used. The item was updated to reflect the newly proposed OHA approved screening tool process. The text change brings the definition in line with Appendix 2, which we'll be discussing later in the presentation. Element 12 is about entering into an agreement with at least one CBO that provides services in each of the 3 domains. We simplified the example in activities meeting this element to make it clearer. Element 13 is about conducting an environmental scan of data systems used in the CCO service area. We made a grammatical clarification and deleted a reference to the CCO Health Information Technology or HIT roadmap. The CCO HIT roadmaps had included SDOH a couple of years ago, but the roadmaps no longer include this information. The reference has been deleted because it is no longer current. Any questions on the component one clarifications?
I'm not seeing any questions in the chat. I would just note, and sorry if you already said this, Katie, but there are several reference documents that were attached to the tag email that went out yesterday, and then also are available on the CCO tag website. The link for that is further up the chat if you don't have it. So if it would be helpful to reference anything while Katie is going through the presentation, you can look at those documents.
Thanks, Jen. All right, I'll keep going and we'll have question period at the end as well. All right, now for component 2. At the April Metrics and Scoring Committee meeting this year, the committee voted to postpone the start of the hybrid sample from measurement year 2024 to measurement year 2025. OHA recommended the postponement to provide more time for CCOs to focus on building the structural components necessary for the measure success through component 1 and to refine data capture and sharing processes for component 2. The postponement also gave OHA more time to track similar newly developed national metrics and refine component 2 specifications. As a reminder, the goal of the social needs screening and referral measure is that CCO members have their social needs acknowledged and addressed. The measure intent is that member needs are identified for all 3 domains, housing, food, and transportation, and that for all domains where a person screens positive for a need, a referral is given. The intent of the clarifications and changes to component 2 in the measurement year 2024 draft is to better meet the intent of the measure and further support planning for the hybrid sample. Component 2 updates and changes encourage timely referrals, increases clarity on how OHA will calculate each of the 3 rates, and works to finalize the data collection template. Included in the meeting materials with the draft specifications is a logic flow diagram for rates 1, 2, and 3. The diagram shows with examples how each of the rates are calculated based on the flow from one rate to the next. Next slide. The blue text on the screen represents language that wasn't present in the measurement year 2023 specifications. The purple text represents information that was given in the details in the numerator description in the measurement year 2023 specifications. We pulled the purple text into the description of the rates to provide additional clarification. Rate 1 is the percentage of CCO members who were screened in all 3 domains using an OHA-approved screening tool at least once during the measurement year. Note that a person can only be counted once per year per CCO in each rate. Rate 2 is the percent of CCO members who screened positive out of those who were screened. And rate 3 is the percent of people who got at least 1 referral for each identified need. Only rate 1 and 3 are incentivized. We also clarified that for the denominator exception to apply for declining the screening, all 3 domains had to be declined. Members should still be screened for any domain not declined and will count towards the metric denominator. Likewise, for referrals, for the denominator exception to apply, the individual must decline all referrals for domains with an identified need to be excluded. Members should still receive referrals for any identified needs not declined. In the draft document that's attached to the meeting materials, all changes are listed only in blue text. Next slide. OHA wants to incentivize members having their needs met in a timely manner. Each of the domains are vital to individual health and need to be met as quickly as possible. As a reminder, the SDOH workgroup felt that the closed loop referral tracking was not technologically feasible at the time the measure was created, and the measure specifications continue to reflect this workgroup finding. Closed loop referrals are not required. The draft measurement year 2024 specifications require that a referral be made within 15 calendar days of a screening with a positive result for all relevant domains. Other CCO incentive EHR measures or digital measures include a referral timeframe such as ESPER and depression screening and follow-up. Administrative or claims incentive measures are not able to track referrals, instead have requirements for when a visit happened for it to be a numerator hit for the metric. The addition of a referral window brings the SDOH metric into alignment with other incentive metrics. To accommodate a referral window, the denominator rate 1 timeframe would include members screened from December 15th of the prior measurement year to December 14th of the measurement year. Any questions about these component 2 changes or clarifications?
There was a question about an earlier slide, Katie, and I believe it was a direct message to me, but you're the expert, so I'll ask you. It's a request to clarify what is due tomorrow specific to the SDOH metric. I believe it was a feedback opportunity, right?
Sure. Yes. So we probably should have made it due slightly before this meeting, but at the July CCO tag meeting, we had released several months ago the measurement year 2023 self-attestation survey, and that has been open for several months for public comment. We, just to let people know, we have received no public comment on it, and I just wanted to remind people that tomorrow is the deadline for CCOs to submit any feedback on the measurement year 2023 self-attestation report. But today I'm talking about the measurement year 2024 specs.
Thank you. I am not seeing any other questions at this point.
Okay, let's go to the data collection template section. Component 2 guidance and the data collection template are in Appendix 1 of the draft measurement year 2024 specifications. Appendix 1 is brand new this year, and the header for the section is in blue text to reflect that the whole section is new. OHA took this approach rather than making all of the text in the appendix blue to increase readability. For the guidance in Appendix 1, OHA provided more information on how the data collection items should be tracked and what counts towards the metric calculations. The guidance aligns with other digital-based measure guidance, such as that for ESPER measures and the depression screening and follow-up measure. In the measurement year 2023 component 2 specifications, a general high-level outline of the data collection template was given. In reviewing the measurement year 2023 data collection template overview, OHA removed the following fields: screening location, coding approach, data source used, and codes used to identify each domain. If CCOs find these fields helpful, they can still collect the information, but OHA will not ask CCOs to report this information. When removing fields, OHA consulted internal partners and examined feedback from last year's SDOH technical assistance. OHA has added 3 fields to the data collection template that were not in the measurement year 2023 specifications. The first field is a match flag field for the sample only. This will allow CCOs to indicate if a member was part of the CCO for less than 180 consecutive days and should therefore be excluded from the denominators for rates 1, 2, and 3. The date of the screening and the date of the referral have also been added to allow for the calculation of the 15-day referral window for the metric. Next slide. Each of the 3 domains will require these fields to be tracked separately. In the measure specifications in Appendix 1, definitions for all valid values are provided in an additional column. Each domain will require that CCOs track whether the individual was screened for housing, whether the individual was screened for the domain, whether an improved screener was offered, the date of the screen, the result of the screening, if a referral was made, and the date of the referral. Detailed information is given for when the field must be completed in the requirements column. If a non-valid value is submitted, the field will not be used to calculate numerator hits or denominator exclusions and exceptions for the member. As mentioned earlier, a logic flow diagram is provided in the meeting materials to demonstrate how the fields will be used and the criteria for inclusion in the numerator, denominator, and denominator exclusion and exceptions for each rate. Next slide. At the beginning of Appendix 1, general guidance is provided. The bullets represent the main points of the guidance. Please review the draft guidance very carefully as it is new to the measure specifications. It is meant to provide further clarifications on how the rates will be calculated and what information must be captured for the measure. For rate 1, members must be offered a screening in all 3 domains. The guidance clarifies that screening for each domain can occur at separate times. To reduce screening fatigue and potential re-traumatization, OHA encourages screening in all 3 domains at the same time if the member has not yet been screened in the measurement year. For a screening to be counted as complete for rate 1 numerator hits, the result of the screening must be documented for each screened domain not declined. So this means that a positive or negative result has to be indicated in the data collection template. For rate 1, OHA decided not to require the name of the approved screening tool to be submitted, and instead CCO should indicate yes or no for the approved screening tool used field. However, the name of the screening tool should still be documented in the record. The guidance also clarifies that the most recent screening and referral episode should be used if a member receives more than 1 screening in a year for a given domain. For example, if a member is screened in all 3 domains in February, and then in October is screened for food insecurity only, the screening from October and any documented referrals for food insecurity that occurred within 15 days would be used. While for the other domains, housing and transportation, the February screening would be used for those domains. Any questions about Appendix 1 guidance and the data collection template?
Not seeing any additional questions at this time.
Okay. Now for the last section, screening tool and approval processes. Next slide. OHA is introducing a new screening tool approval process. The SDOH measure will still have the preferred SDOH screening tool list. An updated version was posted in March 2023 to include screenings from national metrics, and the link is provided in the slides. The new process will be included in Appendix 2, or is included in Appendix 2 of the measurement year 2024 specifications. However, for the first round of public comment, the draft recommendation for the screening approval process is included as a separate document called the draft SDOH screener approval document, and that is in the meeting materials. To help OHA establish the screening approval process guidance, ORPRN and OHA convened an external screening tool committee. The group met twice and members gave OHA written feedback. The recommendations from the committee focused on reviewing and providing recommendations to improve the original screening tool evaluation criteria and the approval process for CCO submitted tools. OHA took the feedback and added to it to create the new recommendations for the screening tool approval process. As a reminder, by June 30th, CCOs are asked to submit tools for approval for the following measurement year. This year, tools were submitted for measurement year 2024, and OHA received a higher volume than expected. OHA is taking additional time to assess the screenings and will need follow-up information from CCOs that I'll discuss a little bit later in the presentation. Next slide. The new process will have a statewide OHA preferred screening tool list. OHA encourages CCOs and community partners to use tools from the OHA preferred tool list to increase statewide alignment, facilitate easier implementation across different organizations, and streamline data collection efforts. When using tools from the preferred list, CCOs and partners do not need prior approval to use the screener. It will automatically count toward the incentive measures in component 2. The OHA preferred list is derived from Appendix 1 in the measurement year 2023 specifications, and most screeners were chosen by the original SCOH workgroup to be part of the measure. The updated list posted in March 2023 also includes screeners from other similar social needs screenings and referral national metrics. OHA will continue to add additional screeners to stay in line with those national metrics. While tools submitted to OHA for approval can become part of the OHA preferred list, many will be approved for use at the organizational level only. The organizational level tool approval will be comprised of tools submitted by CCOs, often on behalf of community partners and organizations. Tools submitted that are already on the OHA preferred tool list will not be reviewed. The process is only for those screening tools not already on the OHA preferred list. OHA created the organizational tool approval list to accommodate tools that may not be appropriate to use at a statewide level, but are appropriate to use at an organizational level. For example, in June of this year, various CCOs submitted slightly different versions of questions integrated into Epic, a widely used proprietary electronic health record platform. OHA will not publish slightly different versions of Epic questions to the OHA preferred tool list, but will consider them for organizational level approval. As discussed on the last slide, CCOs will submit tools annually by June 30th for the following measurement year. OHA will not approve tools retroactively. Next slide. The following is the criteria for organizational level approval. To be approved, the tool must screen for at least one of the metric domains, both housing insecurity and houselessness, or food insecurity or transportation needs. For example, a tool that just screens for houselessness will not be approved if it does not also include housing insecurity. The tools must be understandable to members and culturally appropriate. Also, central to the measure is screening and referring members in a trauma-informed manner, and the tool should reflect this guiding concept. The tool should also provide the option for members to decline all relevant domains. A person may decline housing questions but want to complete the food insecurity questions. The tool needs to accommodate for these types of scenarios. Finally, for screenings to count as complete for rate 1, the tool must result in either a positive or negative result. For rate 2, the numerator is at least one positive result, and for rate 3, to make a referral, a positive screening result is required. Therefore, the screener needs to provide a clear indication of a positive result for each domain the tool will be used for. Next slide. For the tool to be on the OHA preferred list for a given measurement year, it should meet the organizational level requirements along with at least 3 of the listed criteria. The tool should be either usable in a medical and non-medical setting, tested for validity and reliability, be available in multiple languages, and/or have incorporated input from the community and/or OHP members in the development and use of the screening tool. Next slide. Going forward, for each tool a CCO submits for approval, they will need to fill out a standard form. This form will be available in SurveyMonkey. A draft of the form has been included in the draft SDOH screener approval document in the meeting materials. The form also includes 4 sections. Basic contact information for the CCO and the name of the organization or organizations that will use the tool. Information on the tool, including which domains the tool covers and the population the tool will be used for. And then 2 remaining sections, questions for organizational approval and an additional question section. OHA anticipates that we would approve tools by September of each year going forward. Next slide. This year, we appreciate CCO and providers' patience as we set up the approval process. Originally, we had anticipated improving tools by September. Postponing the data collection on component 2 to measurement year 2025 has allowed us to engage external individuals and community partners to establish a better approval process. In addition, the complexity and volume of the request made us realize a more formal process for approval was necessary. For tools that were submitted by June 2023, OHA will be asking CCOs to submit a truncated version of the SDOH screening tool form. OHA plans to send the form to CCOs after the first public comment period closes at the end of October. Once CCOs have submitted the truncated form back to OHA, we will work to approve the submitted screeners quickly. We really appreciate CCO's patience as we work through the approval process for the first time and gather public comment on it before full implementation. Next slide. Okay, that's the end. And so I hope there's at least a couple questions. Okay, I see some in the chat. What is the due date for the CCOs to submit their 2023 attestations? We have not yet published that timeline. We are planning on that it would coincide with when other self-attestations are due for the upstream measures. And we will be posting a more exact timeline shortly. Any other questions?
Lots of information to take in there. Thank you, Katie. We can wait a few more minutes on questions, or if there's anything else you'd like to share with the logic flow or anything, Katie, I think now's a good time.
I don't think there's anything else that I want to share today, but I am always, Rachel or Brendan and I are always available to answer questions. We take questions through the TA contractor as well as through metricsquestions.com. So.
Okay, last call for questions. I'm not seeing any. Oh, there's one. Can you please say again the timeline of tool approval and submission?
Yes, so each year, so for measurement year 2025, we would be, CCOs would need to submit by June 30th of 2024. And so for the Epic tools, are they approved in bulk? we assess each application individually for different organizations, and what it looks like has happened is different hospital systems have slightly altered the questions to for their patients, and so we're reviewing those applications all separately. We just didn't feel that it would make sense to approve, if we continued with the statewide approved list, that we would want to be posting slightly different versions of the Epic tools. And so that's why we went towards the organizational approval. We also got some submissions where, yeah, so, yeah. Okay, and so, yes, I think that is, yes, that is true, that many of the Epic tools are pre-built and they come directly from existing approved tools. So we would want to know in the form that we're asking for CCOs to submit for each application for approval that, yes, and thanks also, David, for that warning. We are asking that if there's any links or additional information on where the questions came from, that is part of the information that's given to OHA when asking for approval, because we can't always tell where they came from. Yeah, Kat, go ahead.
All right, I'm just going to unmute because I feel like the chatting is hard. So I just want to understand. So the ones that we've already submitted, those aren't going to be approved. We're kind of canceling that process and going back to the drawing board and resubmitting with this new form. Is that what I understood?
So I have all the tools. I don't need them to be resubmitted. I do need additional information about the tools to be able to approve them. So one thing that we realized, for example, when the tools were submitted is I can assume which domains an organization is asking for each tool, but I don't actually know. So we will be asking CCOs to fill out a truncated form for each of the tools submitted, so we know like what domains was the tool meant for, who's the population that's going to be, is it for pediatrics, is it for adults? So there's just some information that we need to say, yeah, this is a form that we approve for these domains for this type of population. And without that information, it's really hard for me to know if the submitted tools are appropriate and meet the measure intent.
Okay, so nothing will be formally approved until after this sort of secondary process, clarifying process, essentially.
Yeah, because I wanted to get feedback from CCOs, community and providers about what we're suggesting is the criteria for organizational level approval versus statewide approval. And then CCOs won't be asked to fill out the full form, but I will for this year be asking for some additional information on the already submitted screeners. Any other questions?
Nothing else in the chat at this point. Feel free to raise your hand if you'd like to speak. Not seeing any right now. So, Katie, thank you. I think folks know how to get a hold of you if they have other questions, or you can always email the metrics.questions email inbox, and then that email will be directed to the appropriate staff member.
Yes, and if you want to take 5 minutes to think about it and come to the Social Determinants of Health Measure Learning Collaborative in 6 minutes, I'll be there as well to answer questions.
That's a good segue.
Yeah.
All right. Last slide then is just a reminder of our next meeting. It is off of our typical schedule a bit due to the holiday. So we will be meeting the week prior, which is Thursday, November 16th from 1 o'clock to 3 o'clock. Look forward to talking with you all then. Thank you.